so much. And so three-modality therapy for bladder cancer, how to define the ideal patient and the ideal clinical scenario. My disclosure have not changed as compared to yesterday, but I have one more today. And this is, I will try to convince urologists in the room here that radiochemotherapy may be proposed to muscle-invasive bladder cancer because he has exactly the same chance of making your patient disease-free and having the same overall survival. I guess this is the most important of my disclosure of the day. So why three-modality approach for bladder-sparing treatment? We may discuss on this concept, but classically speaking, this was based on these three paths. First, a complete TURB, and we have heard from Nick that this may change in the near future. The chemoirradiation phase and the careful follow-up of patients, you will understand why. And of course, you immediately noticed that the role of urologist, even in this path, in the bladder-sparing path, is extremely important. It's not the radiotherapist doing a complete TURB, it's not the radiotherapy doing a complete follow-up by cystoscopy. So this is not stealing patients from urologists, but it's probably in the landscape of GU cancer, in my opinion, the real integration of professionals doing as better as possible for their patients, much more in what we have seen yesterday for prostate cancer. So don't forget that. Why this idea of using radiotherapy together with chemotherapy? You have heard how things will change in the near future, but classically speaking, historically speaking, you have here a lot of reasons. The most important one probably is that we, the radiation oncologists, we have learned from a lot of cancer that we may use chemotherapy synergistically with radiation with what we call a radiosensitizing effect. It's not the same effect we expect when we use chemotherapy, for example, for prostate cancer, docetaxel. This is a totally different biological base. Is the idea of using contemporary these two treatments, and chemotherapy in this respect is used as a radiosensitizer. And this is not, as you can see in the last line here, the only example in oncology. Other cancer, head and neck cancer, anal cancer, are nowadays taking care with this important concept. We know, on the other hand, that radical radiotherapy alone is not a good choice for bladder cancer. There are papers out in the literature. There is a Cochrane database, there is a Cochrane analysis taking into account several randomized trials that you can see here. They don't date, the date in which they were published is not very recent, as you can see, but the idea of treating bladder cancer with radiotherapy alone is not a good one. And you see here that at that time also a preoperative, I've been old enough to have used radiotherapy in the preoperative setting with the idea of making surgery easier. Okay, that's what we thought 20 years ago. But indeed, if you compare this with external beam radiotherapy, the result goes in the direction of saying that surgery is better. So external beam radiotherapy alone may have a role with bladder cancer patients, but is not will not give you the same overall survival benefit as a surgery. It may be used to palliation. We are very effective in palliate symptoms, hematuria, pain, local pain, but certainly not in this respect. And indeed, if you look to the EIU guidelines today, they clearly say, and this is a strong rating, do not offer radiotherapy alone as primary therapy for localized bladder cancer. And then we came to the subsequent point, how to define the better candidate for a three-modality approach and a bladder-sparing strategy. I like this sort of cartoon here because you have a continuum definition from left to right to what we can ideally think as an ideal candidate for bladder preservation, and on the right side, what are the contraindications for bladder preservation. We will challenge this. This is very rigid, but you will see that this is only part of the story, okay? But for the moment, I think it's quite important to bear in mind that not all patients diagnosed with a muscle-invasive bladder cancer may be good candidate for a three-modality approach. And this is something that you have to take into account when you will see the next patient on Monday morning. I prefer this slide that I've been stealing to Nick James a few years ago. I guess he doesn't even remember when he gave me this slide, because it's a list of the reasons that make you think that the patient you have in front of you is unsuitable for a bladder-sparing approach. Of course, some of those are very straightforward, because the reason why you may propose a bladder-sparing approach is to preserve the bladder. And if your patient presents on Monday morning with a poor bladder or a highly symptomatic bladder, he is probably the first one, your patient, that doesn't want to preserve the bladder. So I like very much this idea that these are the two most important reasons which make your patients not a suitable candidate for chemoradiotherapy. But then you have other here in the list, and we will try to understand what happens in the real world of series of patients that have been treated historically with a chemoradiotherapy approach. Did all these series exactly match this list of reasons that you have seen here? Well, this is not probably the case. You know that historically we have two ways of going for a radiochemo approach. This one is the American Massachusetts General Hospital way. They do what they call an induction chemoradiotherapy, concurrent radiochemotherapy. They reevaluate with cystoscopy what is the result that has been obtained. Don't forget that the dose that is used in terms of radiotherapy in this induction phase is not the radical one, so that after the repeated cystoscopy, we will go to a full dose radiation and chemotherapy only if the patient will be a complete responder. If not, they say, well, this is the moment to go for a salvage cystectomy. Okay, so this is a two-step scenario. But what is interesting is to check, and this is probably the most important series of patients treated at the Massachusetts General Hospital with this technique, look at the kind of patient that they have been randomizing here. If you look correct, well, this is the other, this is first of all the other European, much more used way of doing. So we go for radiochemotherapy till the end, to the maximum dose of radiation, maximum dose of chemotherapy. We don't have any intermediate step in which we evaluate the response. I have to admit that this is much more easy to organize in a busy department. You don't want to lose your patients, send it back to the surgeon to have a cystoscopy in between your treatment to check the response. And this was especially the Erlangen colleague, German colleagues that have published on this. But the point I want to make is that if you look to their statistics, if you look to the population of patients that in the real world have been treated with this technique, well, look, this is the American scenario, Massachusetts General Hospital, and you have T4 patients. Do you remember in my list of the ideal candidate, T4 patients were on the right side of the cartoon. You have patients with hydronephrosis, 16%. Again, patients that normally you should find the right side in the non-ideal candidate. And you have one patient out of 4 with CIS. So in the real world case scenario, the patients we are treating with radiochemotherapy are probably not what we think are the best ideal patients. Don't forget that, because the result, anyhow, that this association obtains in this series, you can see here the overall survival of patients is not that dramatic. And don't forget that 8 patients out of 10 retain their bladder. Okay? And the same for the more European way of proceeding. This is the Erlangen series. You see again that we have T4 patients, even CN plus patients. Typically, these are patients that were refused for surgery. You understand? But still the result, hydronephrosis was not reported, but CIS in something like 20% of patients. Again, not the ideal candidate we are talking about, but still the results are superposable to what is obtained in the States, with 50% surviving at 5 years and 8 out of 10 of those patients retaining their native bladder. I think this is important to remember when thinking about this strategy. And here I have a little quiz for you, because I've put together, it's of course not myself, but it's a paper from Jason Efestasiou from MGC. So we have put together here 2 groups of trial that have tested radical cystectomy versus radical radiotherapy and chemotherapy. And we have here the overall survival at 5 and 10 years. So my question to you is, look at those data and tell me which one pertains to cystectomy patients and which one pertains to radiochemotherapy patients. You don't need to be a statistician to see that the results are almost the same in terms of range. Do you agree with me? And so I ask you to define which one pertains to surgeons and which one pertains to radiochemotherapy. Well, this is the truth. The first 3 studies are cystectomy studies, and the other first are bladder preservation studies. So this tells you, of course, this is not randomized evidence, this has nothing to do with trials, but this is real-world evidence coming from very good institutions, Memorial Sloan Kettering, the ZWOG trial, Erlangen, as I told you, in Germany, and MGC. But no big difference can be shown when you do things properly. And then we have the Zlota paper. I'm sure you are aware of it. It was published Lancet Oncology a couple of years ago. And of course, in absence of any randomized evidence, because this has been tried, we also tried this in France in the frame of the G2 group. It was impossible to randomize patients to such different surgery, radiation, chemotherapy case scenario. Patients have their own very strong ideas about what they want, so very difficult, at least French patients, very difficult to randomize them. What Zlot have done, he has done what we call a propensity score match analysis, which we can discuss for hours. Is certainly not the best way to compare different treatment, but what he got, I think you are well aware of this paper. Well, the criteria for patient selection were very strict. You didn't want patients with big cancer, only unilateral, eventually, hydronephrosis present, and no multifocal carcinoma in situ. He found out 700 patients from 3 American and Canadian institutions, again, some good ones, Massachusetts General Hospital, Princess Margaret in Toronto, where he works, and the University of South California in Los Angeles. And you know the results, but if you look to the kind of population that he found, again, and this is what real life tells you, you have people having carcinoma in situ, you have people having T3, T4 cancer, you have people with hydronephrosis. So this is just to insist on the concept that you may have the ideal candidate in your mind, you would like to treat only these patients, but then in the real life, this is what happens, even when you try to get numbers which are really very, very selected. You know the results, no difference. Again, we don't need to be statisticians to see that there is no difference in metastasis-free survival, distance-free survival, cancer-specific survival. There is a little difference in overall survival of favoring radiotherapy and chemotherapy, but we cancel it. I don't want you to panic. Let's say that there is no difference in all major endpoints when you compare these two populations of patients. I forgot to tell you, of course, that Alexander Zlota is a neurologist, is not a dangerous radiation oncologist. So the conclusion of Alex is very clear, no difference in all these endpoints. And what is important, the patient that he picked out would have been eligible for both procedures. So he get treated for the enormous bias in this population of patients deriving from the fact that the patients may be selected. You will not do cystectomy because you are not good enough. Let's do something else. No, patients in this series would be eligible for both treatment. What did we learn from the Zlota paper? I have tried to put it here. Well, first of all, salvage cystectomy may be needed in those patients. I'm not telling you that nobody needs salvage cystectomy. It was quite a number of patients, 13%. Only one patient needed salvage cystectomy because of toxicity. This is also important and I guess reassuring for our patients deciding for this treatment. Recurrences were evaluated very specifically. Non-muscle invasive recurrence, 20% of patients, muscle invasive recurrence, 11% of patients, and all the recurrences in this series occurred within 3 years. So it really seemed that 3 years follow-up is the dead point, okay? On the right side you see, but this I leave for the urologists in the room to get what are the principal message out of this paper. So, yes, these are a couple of slides just to tell you that the quality of life after TMT is not worse than the quality of life after cystectomy. This is also good news for the patient that will decide for this technique, but probably the most important question is this one. And again, this is what as Nick James has been teaching me. So, is surgery better than radiotherapy for local control or the other way around? Well, probably this is not the good question. It doesn't really matter. What matters is this one. Do we have salvage surgery that can be performed efficiently in the patients eventually relapsing if they decided to go for trimodality therapy? Because if we can offer them a very good salvage treatment, well, we may spare a lot of bladder in our patients knowing this. And what does the literature tells us? If you compare radical cystectomy with salvage radical cystectomy, we have some series out there. And at the end of the day, and you can see here the p-values when you compare the complication rate of these two strategies, so immediate cystectomy or cystectomy only as salvage, these P are not very different. Of course, I know your question, yes, but this is coming from of centers, high volumes, and they have a lot of experience on this, but probably this makes us thinking that this is the way to go. Look, the adjust cancer-specific survival of primary cystectomy versus salvage cystectomy, again, blue and red line are superposed. And again, this must be very reassuring for our patients. I don't go, Nick has already a little bit give you an idea of what we may see in the near future in terms of biomarkers of tumor response. Just to give you a very understandable example in all these, if you have biomarkers defining which patients are best served with cystectomy or which patients may be best served with a radiotherapy approach, well, this will be something that may be helping a lot on Monday morning when deciding what to propose to our patients. And these may be integrated in a cascade of different biological markers that can be used, that will be used to better define the strategy for all our patients. So, my conclusion are the conclusion of, for once, are the conclusion of VIU guidelines. They have been fighting about that because we, the radiotherapists, we wanted to make clear that these strategies of bladder preservation should not only be proposed to patients not good candidate for surgery. Too easy. No. Long-term survival rates for TMT bladder preserving treatment are comparable to those of early cystectomy. The contraindication should be discussed with patients, but endpoints like overall survival should not be used anymore to guide your patient in one direction or the others. Offer surgical intervention or three-modality bladder preserving treatment to appropriate candidates, and this is what we should do in our consultation every day. And the candidate should be clinically assessed by at least an oncologist, a urologist, a radiation oncologist, as we have learned to do for prostate cancer. So in my idea, these two paths, at the end of the day, should come to the same direction, which is put the patient in the center of our reflection. I thank you for your attention.